moving now to talking more about symptom relief. We are going to spend some time talking about palliative care and debunking all of the myths that go along with palliative care and really talking about what resources it can provide throughout the trajectory of having a brain tumor. So I would like to introduce and welcome to the stage Dr. Akanksha Sharma. She is an educational powerhouse, people. She is triple boarded. She is board certified neurologist, neuro-oncologist, and palliative care specialist. But what I have to tell you is even more impressive than her brain is her heart. So I've met a lot of physicians in my time in this discipline, and no other is more patient-centric care than this one right here. I'm so excited for this presentation. Dr. Sharma.
Thank you so much. That is such a kind introduction. It is such an honor for me to be here. Thank you so much. This is quite an amazing experience, my first ABTA conference. Thank you to Dr. Lowen for inviting me. I am thrilled to be here and thrilled to talk about my favorite topic, which is how we integrate palliative care into neuro-oncology. And what Dr. Logan told me was that you need to make sure that people listening will understand what a resource palliative care is and stop being scared. And when Dr. Logan tells you to do something, you do it. So I'm thrilled to be here, and this is especially close to my heart, and this is what I love talking about, really, because I became a neuro-oncologist because I watched someone go through an experience with brain cancer where towards the end of their life, they really did not have the support that they should have had. And if we had started earlier, it could have been so much better. And that's what directed me towards becoming a neuro-oncologist and a palliative care specialist. These are my disclosures. They're not relevant. So today we're really going to talk about what palliative care is, how it's different from hospice. I really want you to leave this room realizing it's not the same thing in America. Who makes up the palliative care team? When does it get involved? How does it get involved? Who can help? And how will it fit in with my care? So before I tell you my story, and I'd like to know if anyone in the room has already had experience with palliative care, has a palliative care doctor or team, or had palliative care involved in their journey in the past. Okay, so very few, and my goal next year is that more hands will go up, because after this you'll just go home and message your doctors about palliative care. So I'm gonna tell you the story of Ben. Ben is an amazing, amazing human, and I have his permission to tell his story. I'm so lucky to know him. I'm so lucky to be involved in his life. But Ben is very young. Ben, 8 years ago, was a healthy software engineer. He had no significant medical problems. He had just gotten married to the love of his life. And his father had died from a very rare neurological condition. And so he, being very savvy, started noticing problems very early. And he had balance issues and numbness of his tongue. And this is what his scan showed back then. So this was a while ago, and this morning in Tumor Board we mentioned DMG, and this is really very early in the course of DMG where we often couldn't get biopsies of brainstem tumors. And so he was diagnosed with a brainstem glioma, and he saw one of the best surgeons in the country who said, I can't even get a biopsy. He is very, very savvy. He found out some of the latest research and got a liquid biopsy. And through that liquid biopsy, he was found to have a H3K27M midline glioma. So I did not know Ben back then, but I imagine what he went through. And over the years, I have developed this model of thinking through how a patient and their family go through the journey of a brain tumor, whether that's a glioma, whether that's brain mets, whether that's meningioma, any type of tumor. I like to think about it in an organized fashion as systems of different experiences. So what happens is initially you have diagnosed, you go through the initial treatment, and it's just a whirlwind. Like all of you who have gone through it know that it's just this lightning shock, and then you are thrown into this world. You don't have a lot of time to think about it. Like this morning, everyone was like, get a second opinion, but how do you have time to get a second opinion? Sean and I were talking about this earlier. So it's a whirlwind. There's anger, there's grief, there's shock, and there's a lot of things happening. And then you kind of get used to it. You starting your treatment. There's a lot of symptoms. You're trying to figure out what's normal, what's not normal. And then once you kind of get into a steady state, you're okay, but then recurrence hits. So recurrence comes, and that can be, again, whether you have a brain met or glioma. Recurrence can happen once, it can happen twice, it can happen multiple times, and each recurrence is sort of realizing like, okay, this has happened again. What do I do now? Where do I go now? How many opinions? What happens now? And there's new symptoms to deal with, there's new side effects, there's new drugs and treatments and their side effects. And then gradually you go into phase 3, which is the later stages where you're probably having more symptoms, more side effects. Really have to think about, is my life going to end, unfortunately? And preparing yourself, your family is preparing you, however it may look like, but getting ready for that unfortunate end of life. And then there's also a phase 4 bereavement, where a lot of our amazing people in the room today who are previous care partners are here, and they're in that bereavement stage of finding meaning and figuring out what they do with this experience they had. And so the reason I divided up into this journey in phases, and this actually came from one of my mentors, Dr. Philip in Australia, who developed this kind of model of care, is that if you think about it this way, you can think about what different needs patients and families have at different points of the journey, and make sure you address those needs in that timely fashion. And we'll come back to this because we'll talk about how palliative care can meet a lot of these needs and where it might fit in. So again, I didn't know Ben, but I can imagine a lot of the things that he went through, and now that I've talked to him, I know that these were some of the questions that ran through his head, right? He's a young man, and he said, how will radiation affect me? Is it gonna change me? Will I be normal? Will I be able to think? Will I lose my hair? He had watched his father decline neurologically, so how will this affect me? Will I be able to function or work? And he had a lot of anxiety. He had panic attacks. He was trying to figure out how I deal with all of these symptoms and how do I cope. He had just gotten married. You know, can I have kids? Should I have kids? How do I move forward? Who's going to support my wife? There were financial concerns. He was an engineer who was working, and how do I support my wife and my family? How much will this cost? Can I afford the cost? And then, of course, you have this existential, spiritual feeling that Dr. Logan also mentioned this morning, like, why did this happen to me? Why us? Why now? And what did I do wrong? How much time do I have? So there are all these domains of areas where people are going through a lot of suffering, right? These are all questions, but when you don't have answers, you suffer from that. This is suffering. So he started radiation and 6 weeks of chemotherapy, and then during that, because it was the brainstem, he had a lot of swelling, a lot of symptoms. He started having difficulty walking, hair loss, difficulty swallowing, slurred speech. And the majority of people he had consulted with had told him, well, you know, you're lucky if you're gonna make it a year, so this is all like part of your journey, it's typical. And so he did Avastin for radiation necrosis, and then through, again, his own will, he found a experimental drug treatment, and he enrolled in a compassionate use drug program for that experimental drug. He didn't qualify for the clinical trial, so then he found another way to it. And so we'll come back to that, but in this phase where he thought, okay, I have recurrence already, it's been a few months, but I already have recurrence, he's thinking about all the symptoms he's getting, what's normal, what's not normal. He's thinking about his thinking, like he can't think normally, he can't work as an engineer anymore. Will he ever go back to work? Is it even worthwhile going back to work if he has 6 more months? Again, the fear of dying, the fear of even going to sleep because he may not wake up because it's in his brainstem. And then who is my support system? Who helps me plan for the worst? How long will I have insurance? What happens if I finish my disability and I can't work anymore? And then, of course, the fear of dying. But more than that, for this young man, was like the fear of being completely disabled for a long period of time. So now we're going to move away from Ben's story. I promise I won't leave you hanging, but we'll come back to him, and we'll talk about palliative care. So what is palliative care? So this is my favorite definition of palliative care. It comes from B.J. Miller, who is a palliative care physician. He's kind of a palliative care rock star, and he has great TED Talks that I recommend. But he himself almost died as a young person, and he kind of gained this understanding of life and meaning. But it's the simplest definition and makes the most sense. It's a multidisciplinary pursuit of quality of life. So it is to alleviate suffering, it's to live a better life, it's to, and to just have better quality of life. And everyone deserves that, whether you have a serious illness or not. But patients with serious illness especially deserve that because their life is so impacted by what they're living through, right? They're so debilitated, they can be sick, they can have side effects, they can be scared, all of the things I just told you about Ben. And so patients deserve quality of life. And palliative care in serious illness, there's been lots and lots of research on this, improves quality of life and reduces suffering. So if you use palliative care skills, which I'll discuss what that is, then you can make patients feel better. And that's by addressing their needs, really going through all those domains that I just mentioned, and I'll mention again, physical, emotional, social, spiritual, financial, all the different aspects, and supporting both the patient and the care partner, because palliative care really recognizes that care partners are an important part. Our patients can't do well unless our care partners do well. If a patient is going through a cancer journey or serious illness journey, and especially a brain tumor journey, if they lose their care partner, they are not going to make it successfully out of that journey. So that is a significant, what we call negative prognostic marker. And so number one thing that people say when I talk about palliative care, or they've been told about palliative care, oh, no, I don't want to do palliative care because that means giving up. I don't want to see palliative care. Are you saying that I'm dying? Are you saying that I'm going to die? Right? Does it mean I'm giving up? Not according to the research. When patients receive palliative care, and this has been done again and again and again in many advanced cancers and neurological conditions, patients feel better, they have less symptoms, they have better mood, they have less stress, and their caregivers have significantly less stress. They better understand their illness. Everyone, the patient and the family, better understands their illness. They communicate with their team better, especially in this day and age where our healthcare system is so insanely difficult to navigate. You have a better communication with the doctors, and you spend less time in the hospital. And actually, patients who got palliative care also lived longer in a lot of conditions. Not every condition, but a lot of conditions. If palliative care was a treatment, it would be put in a pill and would be being sold for I don't know how much. You know, one of the newest drugs is like $50,000 a year. Palliative care would be way more than that, because that's how successful it's been in trials. It's also saved hospitals money, it's saved doctors money. So why are people still so scared of it? Because it's hard to do, it's hard to provide. It's not a long-term gain, not a short-term gain, it's a long-term gain. And people don't want to invest time and money into something that's long-term, that they can't see right away. And so you're not receiving something that's really important because you're scared of it, but in reality, it actually could help all these different aspects of care, all these different aspects of your life if you received it. How is it different from hospice? Is palliative care hospice? That's the number two. So first thing is, does it mean I'm giving up? And the second is, isn't that hospice? So how is it different from hospice? So when you're diagnosed, you know, that lightning bolt hits you and you have this long journey ahead and everything is going to be different from that day onwards. You're going to have hospital visits and injections and medications and pills and doctor's visits and so many different things. Palliative care fits in all throughout that journey. Palliative care can happen while you're getting treatment. It does not need for you to have a terminal diagnosis. It's focused on needs, not on the prognosis. So it doesn't even ask, like, is this person going to die or not? It's just focused with we're all going to die, but in terms of a shorter terminal illness. It's focused on needs, not prognosis. It's outpatient. Sometimes it's inpatient. Sometimes it's at home. It's kind of like seeing a specialist. So you see your ear, nose, and throat doctor, you see your neuro-oncologist, you see a radiation oncologist, and you see a palliative care doctor. Why did palliative care have to occur? Is that everyone was getting so subspecialized in their specific area. You can now be a medical oncologist who only sees lung cancer in the US. You can now be a radiation oncologist who only treats head and neck cancer, right? That's super specialized. So what that means is that you're only focusing on one area and the big picture is lost. And so palliative care came out of that realization that no one's looking at that big picture. No one's looking at how the person is doing overall, how their family is doing, how that home organism is doing. And that all has an impact on the patient. And then palliative care at the end of life is hospice. So it's the same things, the same principles, but now you have different goals. You're not going to treatment anymore. You do have a shorter prognosis of 6 months or less, and that was determined by Medicare and not based on any specific research, but regardless, that's the rules we follow. And usually when you are on hospice, you can't get treatment anymore. The exceptions are veterans and pediatrics, which I won't go into, but just to briefly mention that most hospices, you cannot continue treatment. And it can be wherever you live, and it's generally a covered benefit. So palliative care is everything that happens before you're ready for that stage. And it can fit in any of those parts. And a lot of people say, well, if I go to my palliative care appointment, are you going to talk to me about dying? I'm scared to talk about dying. but palliative care can actually be life-affirming. It can be life-valuing. It talks about who you are and what's important to you and what is important to you in your life. What do you want to make sure happens in your life? It focuses on coping, a lot of the beautiful things we've heard this today already from all these great researchers. And it does talk about death, but it sees death as a natural part of life. So palliative care specialists are not afraid of death, but they want to say that what is important to you in your life before that comes, and how can we make sure that when it comes, it's as smooth, as painless, as worry-free as possible for you and your loved ones. So who provides palliative care? So there's an amazing palliative care physician who's an artist. I'm very jealous of his art. His name is Nathan Gray, and this is his website. He does some amazing cartoons, but he developed this like national park-like examples of palliative care. And it's an interdisciplinary team. So there's an interdisciplinary team that's made up of a number of different specialists, and not just one person. And they help you navigate, and I really like this, the one on the right is the peaks and valleys of serious illness, which we were also just mentioning. Several people are part of the team. So you are part of the team, you and your family. The care partner is working with me to take care of the patient. I see them as part of my team, but also there's an advanced practice provider or a PA or an APP, a nurse navigator, a social worker, a chaplain, and then if you're really lucky and you have funding, you have psychologists and counselors, amazing people that are sitting right here. We have therapists, nursing assistants, research staff, administrative assistants. So palliative care looks differently in your organization, in your area, in your community. It might be an outpatient doctor. It might be one doctor for the whole town. It might be a huge cancer center which has all the resources you could possibly need, but you just didn't know existed. It could have somebody having an acupuncture therapist. So there's a lot of different people that could be involved, but the mindset that we're all trained under is interdisciplinary. Like, okay, if a patient has X symptom, how can I get Y or Z to come and help? Or how can I get them into something? So one of my patients messaged me today who I used to do trigger point injections because she had pain from a previous surgery. So that was not her main treatment anymore, but it was something that was an adjunct to help her feel better and make her feel better. We all are working together to support you. So where does it fit in? So this is an image that my collaborators and I made for brain Mets patients, but it applies to really any brain tumor patient. So there's, in an ideal world, in a perfect world, when insurance covers everything, we have all these specialists who are involved, right? There's neurosurgery, medical oncology, radiation oncology, social work. They're all an equal part of the pie, and part of that pie should be palliative care. Ideally early on, ideally from day one, but depending on your resources, it might happen later, which I'll touch on just briefly. But multidisciplinary care is key for brain tumors. So that's what we've been discussing all day, and part of the tumor board was that multidisciplinary experience. Now, it doesn't have to be just in an academic center, I will say that, right? I work in a community hospital. I love working in community hospital systems because I think that's where that expertise is needed, and that expertise exists. It's just different and difficult to find. And not everyone is able to go to MGH or Duke or Sloan Kettering. That doesn't mean that you shouldn't have those resources in your community, and you probably do. Some of the best palliative care doctors I've met are in small towns and all over the country. And so it's not about getting to a huge center. It's about having those people. It's about having the people who are thinking about you, who are focusing on you as a person, not on your disease, who are focusing on what is important to you and taking that into consideration for the plan that they're making for you. So what kind of ways can it help me? So I like to think about palliative care with a foundation of high quality communication. So these are doctors, these are not the doctors you say, you know, they're really good, but they don't have good bedside manner. That's not a good palliative care doctor. You know, you want a palliative care doctor to have a good bedside manner, to be able to build a rapport with you. It's a multidisciplinary team. It's more than just what's happening in here. It's about what's happening in your whole body. Adam Hayden, who often comes to this conference and is a GBM patient advocate, says, you know, the neuro-oncologist was worried about my chemo. The palliative care doctor was worried about me. Like, how was I feeling? And so those are our very important parts. I like to divide it into these 6 areas. how are you feeling? What are symptoms are you having? How can we better manage your symptoms? How are you navigating this crazy, crazy healthcare system where you have multiple specialists and multiple people and everyone has a different idea of what should happen? Are we thinking about the future? Are we planning your legacy? Even if you have 5 years, 10 years, 20 years, we expect you to live a really long time, but still, can we think about your future? Is everything ready and prepared? Planning for the worst, but hoping for the best? Are we providing you spiritual, social, psychological support? Are we thinking about health equities and disparities? And then shared decision-making and disease understanding goes hand in hand. Do you understand what is happening to you? Do you understand what this means? Has it been enough time that you've processed it and you've gotten all your options, and now you have options between 3 clinical trials? Which one do you pick? Or now you have an option between doing another surgery or not, as some of the questions we had this morning. So all of those questions and decisions are really difficult to do alone. And what if you had somebody who helped reframe it in a manner that made it easier to make your choice? What if they got to know your goals and values and said, you know, based on what I know of you, this option A might be better than option B. And it's both for the patient and for the care partner. We heard such a great discussion on care partners, but it's important to note that while there are care partners in every type of cancer, patients with brain tumors, their loved ones are experiencing a higher level of distress because there's higher dependence and higher needs. No one's fault. This is just the nature of the disease. And there's neurological and psychiatric symptoms. It's isolating because here we're all together, but in our communities, we may not know somebody else who's going through the same journey. And the other thing is that there's a huge discordance in disease and prognostic understanding. Let me explain what that means, because it's not completely clear. I was just thinking about this. I lost one of my uncles. He's very young. He was very young to colon cancer this week. And he really, in his last day, had everything planned out. He had planned for his funeral, which is going to be next week. He had a last meal that he had all his family there. They all hugged, and I saw this beautiful picture my aunt sent of him surrounded by his family. And he was very aware. He was a physician himself, so he was very aware of everything that's happening. That is not the experience that most of my brain tumor patients will have. So another one of my patients who I have followed for years, his wife called me and he just enrolled on hospice. He has no idea what's happening. And he had wanted to do death with dignity in California. That's allowable. But now he's talking about what he's going to do next summer, when he's going to come visit me, how things are going to go. And that doesn't happen all the time. But when it happens, it really creates this discordance, which is very distressing, right? You want to have those conversations, those end-of-life conversations, those like, we had a great life together, that feeling you want to have. And you don't get that. But also, you're living on a very different plane than the loved one, right? The patient is living on a different area than the caregiver, and so there's this fear, like, are the doctors seeing what I'm seeing? Are they understanding what's actually happening at home? And in America, often they're not, because they're not looping in the caregiver. So that's why palliative care becomes even more important. So if back then I had known Ben, and Ben had this initial phase and initial diagnosis, and he had all these questions, then there are many, I want to kind of group it into how it would fall into our care. So firstly, he would have these symptoms, his balance, his swallowing issues, and we talk about where they might go if best case and worst case scenario. We would talk about his disease at that time. We didn't have a lot of treatments. We'd talk about how he can cope and work with it, decision-making support. We would talk about the future, make sure he banked his sperm, which he did. Spiritual, social, and psychological support, making sure his existential distress is addressed. When he had recurrence, again, we would talk about symptoms and see how he's feeling, how can we make him feel better, have him go through have a coordinated system of care to send him to this clinical trial so he didn't have to do all that work himself. Like, help him find this trial, help him find this program and get him on there. And then again, plan for his future and his legacy. So when can you access palliative care? So palliative care referrals, or how can you access palliative care? So it can come from your team, but I'll be fully honest here. A lot of physicians in this country still have a wrong understanding of palliative care. Either they think that it's hospice, or they're scared of it, or they think, and this is the truth, a lot of physicians have a lot of ego, and they want to be the main person in your care. And so sometimes they won't involve people who should be involved. But then the reality is palliative care is a rare resource. And so there's only 5 of neuro-oncologists who do palliative care in the country, in the whole country. But so it exists, but it may be that your neuro-oncologist is just so good at palliative care that they're doing all these things at the same time. But it can also come from your request. If you're not getting that care coordination, if no one's asking you about your symptoms, if no one's asking about your future, then you can request it. Your family member can request it. And you can reach out to organizations like the ABTA, the Brain Tumor Network, Get Palliative Care, National Hospice and Palliative Care Organization. So all these different organizations will have resources or directories that you can get to. And if you are getting care in a cancer center, they'll have a directory where you can find a palliative care specialist. Anytime is a good time for palliative care. But as I said, it is a resource that's not in huge amounts everywhere, although now with telehealth it has helped a lot. So sometimes I say, well, maybe you involve them when you're having symptoms, when you're worried about the future, when you can't understand where your disease is going, when you're not getting a lot of answers. A lot of my consults used to come from, no one's ever talked to me about prognosis. And so that's a great reason. When you're having trouble navigating healthcare, my neurosurgeon isn't talking to my radiation oncologist, and this person is saying get surgery, and the radiation oncologist is saying get another round of radiation. What should I do? When you're frustrated about your care, when your family needs more support, right? Maybe it's not you, maybe it's your family, and there are ways that the family can get support if you are also part of the visit. When you need additional support for any reason. So palliative care can be a good resource in those times. And I would say one of the lessons I've learned is that sometimes you have to be persistent, you have to find all the resources. I had a dear friend who had metastatic cervical cancer. And she would bring up palliative care in her visits, and her oncologist would say, you don't need that, you're not dying yet. Unfortunately, she died in 6 months, never having seen palliative care and never having her pain properly managed. So you do have to advocate for yourself, and I hope that I tell you that story to advocate for yourself. So how is Ben doing? So Ben is doing amazing. This is Ben with his wife, and he now has 2 kids. And this is his tumor many years later. Ben responded to the experimental drug that he fought so hard to get himself on. He continues to navigate issues such as radiation, cognitive changes, survivorship, financial management, planning for the future. He actually just gave an interview to This American Life, which is available online, and he talks about some of these challenges, especially as a young man in brain tumor world. And so this is obviously a beautiful story and a great outcome, but Ben still struggles with a lot of those same questions, right? We don't have the answer. We don't know how long he stays on this medication. We don't know what happens if he stops. We don't know how the radiation that he got is going to impact him. And his kids are growing up, and they have a beautiful home, and he has a beautiful dog that he does therapy work with. But when could that change? You know, when would his balance get worse, or what are these? Will the signs of change mean that his tumor is coming back, or will it mean something else? So it's still something that we constantly keep talking about. We do his scans, and we still talk about all these issues. I only got to know him about 5 years ago, but I'm very honored to be involved in his care and be able to look at it from a palliative care perspective. And then I think this will play, but this is something one of my patients actually helped me make.
Having come from a family where terminal illnesses have been part of our history, especially recently, I've also lost some friends to cancer. Caring palliative care for me was, went hand in hand with hospice care, and it meant the end. It was a little off-putting. It was scary. Just led me to assume that my end was here, and it was comfort. I was to be comforted until that happened. When I met you, it was, how can we improve your quality of life, and in what ways can we do this? And it was very supportive. I felt like I had a cheerleader on my side immediately when I met you. Just the impression you gave was bigger picture. It was all aspects of my life, a very well-rounded focus.
I think it's essential. And to be honest, I think it's essential from the beginning. We don't know when the symptoms or when it's going to get hard. You can't predict. And if you wait too long, then you risk the opportunity of not having built a relationship, building trust, knowing, and for the physician to be able to read their patient because they know them, they've seen them when they are really well before they're getting really uncomfortable. I wouldn't do it any other way. As a caregiver, how palliative care helped me is there was this partnership. Like, I knew that I had a partner in caring for my friend. When I would reach out, you were able to understand what I was talking about from more of a, like a comfort lens. And you helped reduce my anxiety as well as, and that helps me as a caregiver not put my anxiety onto my family member who's already really, has a difficult burden to bear.
It's an interesting question. I wouldn't say off the bat I would recommend palliative care. I would more say off the bat, why aren't you doing palliative care? Coming from knowing what it's like and what it's not like, it's like, wouldn't you want to be taken care of? Wouldn't you want your feelings and your concerns to be taken account of, to be heard, to make sure that your whole care team is talking to each other? Getting a cancer treatment diagnosis, it comes like Dr. Sharma told me, it comes really fast, really quick, and there's a lot to navigate on top of your emotional and mental. It's not only that you're going through your treatment, but you're also going through this maze of logistics. And for a team just to come in and help you with all that, the amount of mental and emotional stress it takes off your shoulders, the energy that you save from the stress, it's just better for you when you are going through an active treatment. And to have people there in place to help you out is a great deal and a big help.
Thank you so much for listening, for being open, and I hope that you all are going to walk away from this being more open and less scared of palliative care. I want to thank Dr. Logan and Dr. Ghazadeen for having me, for the ABTA, for organizing this, and for having me here. I want to thank Vanessa. Vanessa put this video together. She's a huge supporter, and Jennifer, Dion, and Ben.
So now you see why I told her she had to come, right? How many people learned something new during this talk? I know I did, and I've been listening to her and amazed by her for a decade now. So we will open it up to questions and answers now. Again, the virtual, those that are joining us virtually, please put it in the actual, I'm missing my word right now. Thank you, into the session that we were just listening to. Do we have any in-person questions right off the bat that we want to get started with? Any hands, or I can go to virtual? Okay, I'll let you guys think. Let's see here. Okay, this is an interesting one. You touched upon it a little bit, but why has my physician or treatment team not told me about palliative care, and or why have they not been able to explain the benefits like you were able to today?
This is a great question. So we are constantly learning more about everything, right? We are learning more, and science is not mathematics. It's constantly evolving. So initially with palliative care, the question was like, why is there a need, right? I'm doing all these things. And then you realize that people weren't getting the same level of care everywhere, and no, you weren't doing all those things. And so the first issue is that a misunderstanding about what palliative care is and what it can offer. Second is this fear of like, okay, well, what is the palliative care doctor going to tell my patient? And is that going to conflict with what I'm going to tell them? So often palliative care works best when the palliative care doctor goes out and shakes hands and says, let's be on the same page before I meet your patient. So when they're involved in part of tumor boards, then it works beautifully. And then the third is, is lack of resources. Like maybe there's not a good palliative care doctor in the facility or a palliative care nurse practitioner, or just not access to that, or they don't know. And that can happen, but there doesn't mean that there's not a team in the community or related to your local hospice. Now that's, again, tricky word, but hospices can have palliative care teams before you get on hospice. So they sometimes are funded to have palliative care separately, and that doesn't mean you have to have hospice. And so that might be a resource. So they may not know where to turn you to palliative care.
Any hands in the audience yet? Oh, perfect. Right back there. A microphone is coming.
Thank you. So I am a 4.5-year meningioma patient. I had a meningioma in 2021, and one of the best decisions I made personally was to get involved with this organization called Brain Tumor Companion, and the executive director's right here, and it's a great grassroots, wonderful, supportive. We've all been through this journey. We're all caregivers and patients right here in this, and so I would recommend you check out Brain Tumor Companion. That's one thing. The other thing is just, how do you find, what's the best way to find a palliative care doctor or nurses or whatever service?
Yeah,
So-
well, thank you for telling me about that. I'm always looking for organizations that support patients, so I'm definitely going to check you out. So I'm so glad that you found a community. And the other important part to note, since you shared your diagnosis, is that patients with meningioma have a very, very high burden of symptoms and suffering. And so that was mentioned this morning, but it's not benign in any way or shape or form. Anything that happens with the brain is not benign. And so, so the one way is through, I listed some organizations. So we have a number of organizations that now have a directory, including the National Hospice and Palliative Care Organization, NHPCO. There's actually a new International Neuro-Palliative Care Society that started a couple years ago, and they have a directory, and those are specialists who are neurologists who do palliative care. Again, there's even less of them, but that's another tool. Or they might be people who are palliative care doctors who specialize in brain diseases, including Parkinson's. The other option is wherever you're getting your treatment to search in their directory. So like if it's MGH, palliative care MGH, and you'll see the palliative care specialists who work there, and you can call their office.
We have time for one more question. I see a hand up. We'll take that one. Thank you.
Hi, I'm a 2-time brain tumor patient. My question is, where is nutrition in this whole thing? Because I am lost in nutrition, and every time I ask a doctor, they have no answers. So where is that?
Very important question. I put it under symptom management. So nutrition should be part of your journey from day one. And you're right, it's not. And for in my case, I work with a dietitian or refer them to a nutrition specialist. But because there's so limited information for brain tumors, I had to educate myself. So someone mentioned that they got like a booklet from their care team. So I have a booklet that I created that creates information on the Mediterranean diet, that kind of provides information on ketogenic diet, yes or no, and what options there are, what supplements you should take. So it really is an orphan area, and it's kind of been taken by palliative care and integrative oncology. So thank you for bringing that up, because it is something that we've sort of adopted. It wasn't something that came into our training either, but because we realized that no one else was covering it, we sort of explored it and take it in. So I've over the years I was joking with Dr. Logan, like should just do an integrative oncology fellowship, and my husband said, no more fellowships.
Please.
But it is extremely important. Nutrition and exercise, the only interventions that have, we didn't have time to go into the symptom management itself, but the only intervention that time and time again shows benefit in patients with brain tumors is exercise.
Wonderful. And I am just going to ask one question that came through virtually, because I think it's a really important one. How often or frequently should a palliative care specialist meet with a patient during their trajectory?
Yeah, that's a fantastic question. So one of the reasons I kind of think about the trajectory is that it's a mental reminder to me. A lot of my patients, I do the palliative care, so to speak, or it's integrated in their care. But sometimes there are some patients who don't want to have that conversation with me for whatever reasons. Like they see me as a different role, or they would rather be. So I refer them out to specialty palliative care. And I love doing that because I have great people I work with. And so I think about it when there's symptoms that I can't manage, or there's symptoms that are getting worse, or there's psychosocial issues, dynamics that I'm not able to get a hand around, family issues, psychiatric issues. There might be disagreements between family members, or they are having significant existential distress, and there are tools that other palliative care doctors might have that I don't have, for example, meaning-centered therapy or acceptance and commitment therapy. So that's when I refer, but from a palliative care specialist perspective, it really, they're more useful when you are actively having some kind of need for them. So it's great to establish with care with somebody, get to know them. You know, it's they'll get to know you, they'll get to know your hopes and values and dreams, and then maybe you see them again in 3 months and do more of the same, but then you see them more frequently when you need to see them more frequently. So there's this new trigger-based approach that has been studied and shown equally beneficial, and it's this, whenever you have a need, you go back and see them. And that might be, you know, I've seen my patients weekly sometimes because their needs were that high. And then when they were stable, I saw them less frequently. So it should change with the way your journey is changing.
Y'all, the myth, the legend, Dr. Sharma in person. Thank you. I think we have a break right now. So we will take a short break, I believe about 15 minutes, and then don't go anywhere because our keynote speaker is coming up and you guys don't want to miss this.